Hi, good evening everyone. How are you all doing? Am I audible? Am I visible? Is everything okay? How's everything? Good evening, good evening. Good evening, Tulsi. Good evening, Adrayan Angelio. That is an amazing name, dude. Anshita, John, SK, good evening, visible and audible. Perfect. So we are here for the MIQ session. That is the most important questions. And what I believe is that the most important questions would be somewhere around what has been asked in the last few exams. So it's more of a extended discussion of what we discuss in the PYQ session. All right. I hope you gave these 15 questions. And how did you find them? Did you find them doable? Was it something that you liked? And were you able to do it? In the last few days, you go for the feel good factor. So you try to do these subjects which give you a feel good. Anesthesia is one of those subjects. All right. That's a decent score, Anshita. Let's see what three questions you missed. And let's see, John, what one question you missed. All right. So during a pre-operative airway assessment, the patient can only visualize soft palate and the base of uvula with their mouth opening and trunk protruded. What is the Malam Patti grade? What is the Malam Patti grade? No, Shiv, I'm not conducting any daily quizzes. If you can just go and see the 60 questions that I gave in the last 12 GTs, and whatever we have discussed in the PYQ session, the MIQ session, and a few of these YouTube lives that we have done, then that is the extent of what I want you to remember in anesthesia. So you don't really need any of the daily quizzes to be upbeat with anesthesia. It is not such a vast subject where you would require so much of trouble. You are already doing a lot of daily quizzes for the bigger subjects, so I'm refraining myself from giving you any more quizzes. All right. So this is a Malam Patti classification. Malam Patti classification. And can anybody tell me what are the structures that I visualize in Malam Patti? So I get it that most of you are saying that the answer is C, but it is not just important to know what is the correct answer. It is also important to know because what is Malam Patti, because it is one of the most important airway assessment tool. It is one of the most important airway assessment tool. Yes. What are you looking for? Push. Pillow, uvula, soft palate, hard palate. Based on its visualization, we have four classes: 1, 2, 3, and 4. Now, only tell me the keyword that you have to remember in each of the class. Keyword. In class 1, you have to remember all structures are visible. What is that you have to remember? All structures are visible. In 2, the keyword that you have to remember is that the tip of uvula is missing. Only the tip of uvula is missing. The keyword in 3 is only base is visible. And key in 4 is only hard palate visible. Only hard palate visible, right? Understood? So these keywords will always help you identify the correct Malam Patti grade. You can see that visualize soft palate, it doesn't matter, but only the base of uvula is visible. So it has to be Malam Patti grade 3. Now, can you tell me the interpretation of this Malam Patti classification? Why are we doing this Malam Patti classification? To assess the airway. So can you tell me the implication of this Malam Patti classification? Yes, the implication is 1 and 2 are considered to be easy airways and 3 and 4 are considered to be difficult airways. And since everybody is so upbeat, let's talk about one more thing, that is, what if epiglottis is visible on mouth opening? Normally, you don't see epiglottis on mouth opening. If epiglottis is visible on mouth opening, what does it tell you? It tells you that this is Malampatti grade 0 and it has no relation to difficulty. It has got no relation to difficulty. It is Malampatti grade 0 and it has got no relation to difficulty. All right. Perfect. So this is about Malampatti classification. Is there any classification which is similar to Malampatti, which has similar interpretation, but you are looking at different structures at different place? Is there a classification like that you remember? Similar interpretation, similar things, but different place. Similar interpretation, similar things, different place. Yes, it is called as Cormack and Lehane classification. And that is when you are doing direct laryngoscopy. And here also the interpretation is same. 1 and 2 are easy, 3 and 4 are difficult. So one is airway assessment tool, another is when you are doing laryngoscopy to prognosticate the airway, whether the airway that you assessed, whether your assessment was correct or wrong. Okay. All right. Question number 2. I might take little bit more in certain questions where I just want you to quickly revise some lateral topics. Otherwise, we'll stick to these 15 questions and a discussion of about 2022 topics. Very good. I'm very happy most of you guys know what I'm talking about, and that is the most important thing in the last few days. Which of the following is not a contraindication to the use of supraglottic airway device like LMA? Not a contraindication means indication. So double negative is a positive. Can you use it in a non-fasted patient? The one thing that we know, that which airway devices are considered to be secure airway devices? Can you tell me? Can you tell me which airway devices are considered to be secure airway devices? Secure. Secure means one that prevents the risk of aspiration. One that prevents the risk of aspiration. So one that prevents the risk of aspiration is a cuffed, don't forget the word, cuffed endotracheal tube and cuffed tracheostomy tube. Apart from that, every other airway device, that is your face mask, your supraglottic airway devices, are all unsecure. That means they do not prevent the risk of aspiration. So can you give it in non-fasted? No. Severe GERD, risk of aspiration? No. Risk of aspiration per se? No. Short outpatient procedure is where you can give it, and we know outpatient procedures are always elective, and elective the patient is fasted. Why short? Because long-term ventilation with a supraglottic airway device can become risky, because some amount of air will keep entering the esophagus, and through that it will keep on inflating the stomach and the patient can regurgitate. So we try to limit the duration of use to short-term use. Okay. Are we okay? Now you want to talk about little bit about supraglottic airway device. Let me ask you some fact-based things. When you place the supraglottic airway device perfectly, ideally, where is the tip of supraglottic airway device? Tip of SAD in front of. Tip of SAD in front of. Yeah, very good. Cuff pressure 60 centimeters of water. Very good. Tip of LMA, tip of SAD in front of C6. Very good. C6. Where is C6? C6 is here. Cricoid cartilage, isn't it? So your supraglottic airway device, which doesn't cross your vocal cords, is in the post vocal cord region of larynx, that is cricoid. Are you okay with this, Anshita? Are you okay with this? You said C6. C6 is a post glottic space. It is the cricoid. Cricoid is the last laryngeal cartilage. Why would it reach there? It is esophagus. Isn't it? It is esophagus. All right. Yes, I know. That is what happens when we are a little bit in a hurry. So don't be in a hurry. Be calm and try to answer things after thinking. You have to do the same thing in your exam as well. Which type of endotracheal tube cuff is preferred? It's prolonged ventilation due to less tracheal mucosal injury. Practically feeding you the answer. Prolonged ventilation due to less tracheal mucosal injury. Tracheal mucosal injury. So we know anything that puts more pressure on the tracheal mucosa is bound to cause more risk of tracheal injury, mucosal injury. So any tube with high pressure is going to cause more injury, while a low pressure cuff has less risk of tracheal mucosal ischemia. Tracheal mucosal ischemia. Less risk of tracheal mucosal ischemia. Alright. Can you tell me the shape of high pressure versus low pressure cuff? Shape of high pressure versus low pressure cuff. High pressure cuff is spherical in shape, while a low pressure cuff is cylindrical in shape. High pressure cuff is spherical in shape, while a low pressure cuff is cylindrical in shape. Alright. Can you tell me max intra-cuff pressure inside a... So now we use only low pressure cuffs. So whenever we are talking about the cuff pressure, we are always talking about the pressure of a low pressure cuff. Low pressure cuff. Yes, 25 millimeters of mercury. 25 millimeters of mercury. 25 millimeters of mercury. That was 60 centimeters of water. That was 60 centimeters of water. All right. Are we good? Kartikeya, 15 is too low. See, the idea is to keep the pressure in the cuff less than the tracheal mucosal pressure. Tracheal mucosal pressure is about 25 mmHg. So if you keep it less than 25 mmHg, then you are safe. You go more than 25 mmHg, then you will stop the blood flow, and that is why you can cause tracheal mucosal injury and ischemia. All right. Question number 4. A 42-year-old female undergoing breast surgery under general anesthesia has a BIS value of 85. What does it indicate? First of all, tell me what is full form of BIS. Can you tell me what is the full form of BIS? Full form of BIS. Forget about the question. First tell me full form of BIS. Are you guys sure? Yes. Bispectral index, scale, score. It is BIS, right? So it is bispectral index, B and I. What about the last S? Scale, score. What is it? Scale, score. Was it? What is it? Is it something? No, remember this is not a mnemonic. Sorry, this is not an abbreviation. So there is no BINS. This is the first three letters of the word BIS. All right. And it is most common used depth of anesthesia monitor. Most commonly used depth of anesthesia monitor. Now the value ranges from 0 to 100, 0 representing isoelectric EEG and 100 representing a completely awake state. And you can see this is 85. Anshita, you should have thought of it by thinking of 0 to 100. 0 to 100, if 100 is so near to being awake, how can 85 be adequate depth of anesthesia? It has to be likely to be aware, because 80 to 100 is normal. 80 to 100 is normal. Adequate depth of anesthesia is 40 to 60 and too deep anesthesia is 20 to 40. 20 to 40. Now, last question from this topic. If BIS is the most common used depth of anesthesia monitor, and remember this question, if BIS is the most common used depth of anesthesia monitor, can you tell me the gold standard? Can you tell me the gold standard? If BIS is the most common used depth of anesthesia monitor, tell me the gold standard. Gold standard is middle latency auditory evoked potential. Which is even better than BIS. This is even better than BIS. Middle latency auditory evoked potential, even better than BIS for depth of anesthesia monitor. For depth of anesthesia monitor. Very good. Which of the following conditions will falsely increase the pulse oximeter reading? Falsely increase the pulse oximeter reading. Falsely increase pulse oximeter reading. So, pulse oximeter. Can you tell me the principle of monitoring pulse oximeter? Can you tell me the principle of monitoring pulse oximeter? Principle. Principle. Beer-Lambert law. Beer-Lambert law. And what is the normal value? 94 to 100%. So it is measuring O2 saturation of hemoglobin. So it can have three factors which are affecting it: false low, false high, no change. False low, false high, no change. Infrared spectroscopy, Kartike? I didn't understand, Vivek. Please don't mark on wrong option. This confused us. I mean, I didn't understand. Which wrong option did I mark? Did I mark any wrong option? I'm marking all the right options only. False, increase, and there is no all except. So there is only one example, carbon monoxide poisoning. No, but Dr. Vivek, I'm not able to understand. What wrong option am I marking? Is there any wrong option that I'm marking? All right. Now, can you tell me all the factors that will cause false low? This is what is important. False low. False low. Methemoglobin, which shows an 85% saturation. Methylene blue, which shows 65% saturation. Then you have peripheral vasoconstriction, as in shock. You have hypothermia, shivering, and you have nail paints. Which nail paints? Blue, black, purple. Which nail paints? Blue, black, purple. Blue, black, purple. Yes, indocyanine green also decreases. ICG, it's a dye. Okay. Question number 6. 45-year-old male undergoing general anesthesia shows a gradual increase in end tidal CO2 from 35 to 60 over 10 minutes. What is the most likely cause? Gradual increase 35 to 60. You remember the clinical approach to capnography that I taught you? The clinical approach to capnography. Does anyone remember that? Clinical approach. I always told you, whenever there is a question, clinical based question, always look at whether there is hypo or hypercapnia. Here what it is? Hypercapnia. 35 to 60. Always ask whether it is gradual or sudden. Gradual or sudden. If it is gradual, then graph touching the baseline, not touching the baseline. Touching the baseline, hypoventilation. Not touching the baseline, rebreathing. Sudden hypocapnia, intraoperatively during CPR. All these situations will be given to you, isn't it? They can't ask you a clinical question without giving a history or a detailed understanding of the situation. So all these points will be given to you. Intraoperatively, sudden and abrupt rise of ATCO2, malignant hyperthermia during CPR, ROSC. You remember this approach? You remember this approach? This is your clinical approach to capnography. This is your clinical approach to capnography. Now, in this clinical approach, where does this question lie? Hypercapnia, gradual, graph touching the baseline. They have not told you that the graph is not touching the baseline. So, can it be hyperventilation? No. Embolism? No. Low cardiac output? No. Correct answer is hypoventilation. A. Hypoventilation. A. Acha, this is what Vivek is saying. Okay, I should not mark the wrong options. It confuses him. So it confuses you, Vivek, when you see a cross sign. You feel a cross sign is the correct answer. I don't understand. Such a simple thing. I am telling you, I am teaching you how to rule out the options. Alright. So when you see a cross, then consider that as the wrong option. Alright. It's as simple as that. कोई बात नहीं. You tend to forget things and you only remember them when you do questions. So in the last 20 days before your exam, you're supposed to do lot of questions. Okay. Lot of questions. Alright. 25-year-old severe asthma presents with emergency appendectomy with acute bronchospasm hypotension. Which induction agent would be most appropriate? So it's an emergency appendectomy. So you have to go ahead and do it. I marked question 3 wrong. Which type of endotracheal tube is preferred in prolonged ventilation due to less tracheal mucosal injury? Thank you so much. I marked it wrong. The question is asking due to less. The answer is low pressure, high volume cuff. Low pressure, high volume cuff. Thank you so much. This is what you meant, Vivek. You should have just written, sir, mark the question 3 answer correct. Now I understood. My apologies. I didn't understand what he was saying. Okay. So now you have two conditions here. One is asthma, another is hypotension. So you want to increase the blood pressure and you want to take care of asthma, that is bronchodilation. Alright, now let's see in IV induction agents what property is seen in hemodynamics. So can you tell me propofol will show what hemodynamic change? It will cause hypotension, bradycardia, and yes, it will cause bronchodilation. Thiopentone will cause tachycardia, hypotension, and it will actually cause bronchospasm. Etomidate will cause no change in heart rate and BP and will cause bronchodilation, but ketamine will cause hypertension, tachycardia, and cause bronchodilation. So the perfect agent in this situation for you would be ketamine. Ketamine. What would be the perfect agent for you in this situation? Ketamine. Perfect. See, you guys almost remember everything. I know, such a nice thing. Very happy. Few days before the exam, anesthesia gives you a feel-good factor. A 60-year-old septic patient receives etomidate for intubation in an ICU regarding adrenal function. Which statement is most correct? What is that you know about etomidate and adrenocortical function or adrenal function? What is that you know about etomidate and adrenal function? So etomidate causes dose dependent inhibition of 11 beta hydroxylase enzyme. Dose dependent inhibition. So more the dose, more number of times you give, more will be the risk. Adrenal suppression occurs only with continuous infusion. Why? Bolus is also dose dependent, infusion is also dose dependent, isn't it? So no. Single dose causes 6 to 8 hours of adrenal suppression. Have we heard a criteria like this? No. Adrenal suppression is clinically insignificant. Can it be clinically insignificant? If it is, why would I discuss it? Concurrent steroid administration prevents suppression. Prevents suppression. This is where I think you got confused the most, isn't it? Yes, I know. No, why 2 and 3? See, if it is clinically insignificant, then why would we read it as a complication? If it is clinically insignificant, then why would we read it? We read it because it is clinically significant. But concurrent steroid administration doesn't prevent suppression. Why? Because the suppression is happening at the level of the enzyme. It is actually causing beta 11 beta hydroxylase enzyme inhibition. So even if you give steroid, it will cover for the deficiency, but it will not prevent suppression. The key word here is preventing suppression. So the correct answer is single dose causes 6 to 8 hours of adrenal suppression. If it is dose dependent, then why it will happen only with a continuous infusion? When you give a single bolus dose, then it is not dose. It isn't a dose. When you give a single bolus dose, then is it not a dose? Is it or is it not a dose? Yes. See, this question I've specifically designed in a way to confuse you. Even when you know everything in the exam, there is a possibility you might make a mistake, and also a seemingly easy question can also trick you. The idea is to just keep your calm while you are doing such questions. You know? The idea is to just keep your calm. Okay? That was the only question which I thought was tricky in this MIQ session. A patient is administered succinylcholine for rapid sequence induction. Muscle fasciculations are noted before paralysis. What is the primary mechanism of action? Can you tell me what muscle relaxant is this? What muscle relaxant is this? No one? Scoline for RSI. What type of muscle relaxant is scoline? What type of muscle relaxant is scoline? What happened? All of you left? Suddenly no activity. Something happened to chat, isn't it? Right. Okay, you guys were answering. Thank you. So scoline is a depolarizing muscle relaxant. Can you tell me what is the mechanism of action? The mechanism of action is partial agonist at acetylcholine receptor. It's a partial agonist at acetylcholine receptor. Is it a competitive inhibition of acetylcholine at nicotinic receptor? No. Non-competitive blockade at GABA? No. Persistent depolarization at neuromuscular junction? Yes. Potassium channel blockade? No. We know it causes persistent depolarization at the neuromuscular junction. Can you tell me why it causes persistent depolarization? What is the reason? You said it's a partial agonist. Then why is it causing persistent depolarization? It's an agonist. It should cause depolarization. It should get metabolized. But why is it causing persistent depolarization? That is the question. Persistent depolarization. It doesn't block acetylcholine receptors. Adrian, does it block acetylcholine receptors? How does it block acetylcholine receptors? No idea. I'm not asking you. Acha, non-competitive. So if it is non-competitive, then it will cause persistent depolarization. Someone is saying non-competitive blockade. Somebody is saying non-depolarizing. I am simply asking you, what is the reason that it causes persistent depolarization? What is the reason that it causes persistent depolarization? That is my only question. Yes. Yes. Again, if it is irreversible blocking, SK, think about it. You are saying it causes irreversible block of the receptor. That means once you give the drug, unless and until it destroys the receptor and new receptors are being made, your muscle is paralyzed. While the hallmark of action of scoline is ultra fast onset, ultra short in duration. So how can an irreversible blockade cause ultra short duration? The reason it causes persistent depolarization is because it gets metabolized by plasma cholinesterase. It gets metabolized by plasma. So the enzyme responsible for metabolism is present in the plasma. And that is the reason why it causes persistent depolarization. That is the reason why it causes persistent depolarization. Okay. Yes. Eventually, because of persistent depolarization, there is closure of time-dependent perijunctional sodium channels. All right. Anything specific that you want to know about scoline? Scoline. Ultra fast onset, ultra short duration. How fast onset? Ultra fast. How fast? See, don't remember that it is not degraded by acetylcholine. Remember that it is metabolized by plasma cholinesterase. Understood? Yeah. Not getting degraded. Okay, it is not getting degraded by all the enzymes in the body except one. So not remembering is not the criteria. Yes. 30 to 60 seconds. Duration less than 10 minutes. This is overall fastest and shortest. Overall fastest and shortest. This is overall fastest and shortest. Okay? Sure. Let's come to 10. A 35-year-old patient with a history of severe asthma and allergic reactions during requiring muscle relaxation. Requires muscle relaxation. When compared, yes, persistent depolarization because of plasma cholinesterase. plasma cholinesterase. When compared cis-atracurium to atracurium, cis-atracurium offers which advantage? When comparing to cis-atracurium to atracurium, cis-atracurium offers which advantage? It's a very straightforward thing, less histamine release. Less histamine release. And if you compare cis-atra, which is like 100% pure cis isomer of atra, pure cis isomer of atra, then it differs from atracurium in 4 key aspects. 4 times more potent, no histamine release, no risk of laudanocin toxicity, and 100% Hoffman's elimination. 100% Hoffman's elimination. All right. And that is why bronchial asthma is probably only one indication where cis-atra is preferred over atra. Otherwise, both are absolutely the same in terms of their use. Absolutely the same. Both of them are absolutely the same. Anesthetic gas with maximum respiratory irritation. You must have felt very good, no? I gave only 2-3 difficult questions. Rest all questions I gave very, very easy. Isn't it? Very, very easy. Maximum respiratory irritation. So tell me, inhaled anesthetic agents, either they are pungent or sweet. Pungent are iso des, sweet is halo, CO, nitrous, xenon. Out of all of this, maximum pungency is seen with des, and an agent that is pungent in odor should not be used for induction. Should not be used for inhalational induction. ठीक है? Yep. And desflurane has a special vaporizer called as Tech 6. Desflurane has a special vaporizer called as Tech 6. Very good. Change is good has put up a very good point. What are the drugs used in anesthesia that release histamine? Also the drugs that should be avoided in asthmatic patients. Histamine releasing drugs that should be avoided in asthmatic patients. Chalo, start karo. Start from IV induction agents. Start from IV induction agents. So you have thio, muscle relaxants, choline, Miva, Atra, and opioids like morphine, imeperidine. Opioids like morphine, imeperidine. Morphine, imeperidine. Perfect. Sure. So correct answer here is C. Maximum respiratory irritation. Question number 12. Which of the following statements are true regarding local anesthetic systemic toxicity? Last. Lignocaine may be used to treat bupivacaine induced arrhythmia. करोगे क्या? Would you use lignocaine to treat bupivacaine induced arrhythmia? Obviously not. The patient has a last. Even if that last causes an arrhythmia for which the treatment is lignocaine, you would not dare give it more. Amiodarone is the drug of choice for treating arrhythmias. Is it? Is there any drug that is useful? I don't know. Propofol may be used instead of intralipid. Absolutely no. See, one, that propofol has hemodynamic change. When you give propofol, it causes hypotension. You already have cardiac instability because of CVS last, so you can't afford to give propofol. Also, if you're comparing the lipid component and you're saying but propofol also contains lipid, so propofol comes as a 1 or 2% formulation, while your intralipid has 20% lipid. How much? 20%. So try to understand the difference. You have to give 10 to 20 times propofol to achieve the same level of lipid in the blood that is required for the being a reservoir. So it is not advisable. Recovery of LA-induced circulatory arrest usually takes less than 30 minutes. Less than 30 minutes would mean it's a recoverable form of toxicity, which is not. It's a very, very resistant form of toxicity. So then how come amiodarone is the drug of choice? Because when there is cardiac arrest and if there is a shockable rhythm and you have given epinephrine and still the patient is not reverting, then as per ACLS protocol, as per ACLS protocol. Nevantha, why would you do trauma life support? Regarding malignant hyperthermia, which of the following statements are true? Which of the following statements are true? Is it an autosomal recessive inheritance? No, it is an autosomal dominant inheritance. Circulatory arrest getting relieved less than 30 minutes indicates that it's a mild form of reason, mild cause of cardiac arrest. Mild form of cardiac arrest. While CVS toxicity is very grave. It's a grave form of toxicity. That is what we wrote. CVS is a late and grave form of toxicity. It is not something that gets cleared up very easily. That is why that is not the correct answer. B. Always occurs within the first few hours of exposure to the triggering agent. May be true, maybe not. Dandrolin 2.5 mg per kg IV, maximum 10 mg per kg. This definitely sounds right. Masseter spasm is the first sign. Masseter spasm is the first sign. Is masseter spasm the first sign? No. Masseter spasm is the premonitory sign, that too when you give it premonitory sign, that too when you give scoline. So this is wrong. And since this is completely right, so this is wrong. And why? Not first few hours. The moment a triggering agent triggers the ryanodine receptor, there is a massive release of calcium from the sarcoplasmic reticulum. So it doesn't take hours. The moment you expose the triggering agent, it will occur. All right. Question number 14. Chest compressions for an adult. Yeah, so if you want to see two complications in terms of EtCO2, so tell me complications in terms of EtCO2. Sudden and abrupt rise of EtCO2. Sudden and abrupt fall of EtCO2. Sudden and abrupt rise, sudden and abrupt fall. Sudden and abrupt rise, MH. Sudden and abrupt fall, venous air embolism. Venous air embolism. Sudden and abrupt rise, MH. Sudden and abrupt fall, venous air embolism. Tulsi, what you are saying is flat capnogram, where there will be sudden and abrupt zero. Sudden and abrupt zero. Flat capnogram. That is circuit disconnection, cardiac arrest, ventilator failure, accidental extubation. Okay. Understood? Sure. 14. Chest compressions for an adult are performed at. Now, this is a very straightforward question. You know the answer. What is the answer? See, when you say cardiac arrest, that is sudden and abrupt fall to zero. But fall doesn't mean zero. Fall means drop. The EtCO2 was 40, suddenly dropped to 12. Fall. That is a flat capnogram. That is a flat capnogram. Any doubts? Let's revise do's and don'ts of high quality CPR for a BLS provider. Chest compression rate 100 to 120 per minute. That means not less than 100, not more than 120, neither too slow nor too fast. Chest compression depth at least 2 inches. That means not less than 2, not more than 2.4. Allow full recoil between the compressions. That means do not lean on the chest. Allow adequate chest recoil. Do not pause compressions. Minimize the pauses to less than 10 seconds. And ventilate adequately. That is, for every 30 compressions, give 2 breaths. Do not over ventilate the patient. Do not over ventilate the patient. Understood? So that is 5 do's and 5 don'ts. And this is, I think, by far the most important question that is going to be asked. It's like a sure shot thing in the exam. So this is the real MIQ. Most important question in your exam. Last question. What is the function of PEEP in mechanical ventilation? What is the function of PEEP in mechanical ventilation? Can you tell me what does PEEP stand for? What does PEEP stand for? Okay, so I understand that it prevents alveolar collapse, but PEEP stands for positive end expiratory pressure. PEEP, and you call it PEEP when your patient is intubated. Can you tell me what would you call this PEEP if your patient is non-intubated, non-invasive ventilation? If your patient is non-intubated, that is non-invasive ventilation, then what will you call this PEEP? You will call it CPAP, continuous positive airway pressure. Continuous positive airway pressure. Now it is what the name is. It is what the name is. What is the name? Continuous positive airway pressure. Positive end expiratory pressure. At the end of expiration, you keep a pressure to keep the alveoli open. To keep the alveoli, to prevent the collapse of alveoli. What does it do? It improves oxygenation. It improves oxygenation. PPV, full form, positive pressure ventilation. For that, you have to understand what is negative pressure ventilation. So when your diaphragm goes down, your chest expands, there is a negative intrathoracic pressure suction that sucks the air from outside. Negative pressure breathing. But when you take a ventilator and you push the air in the breathing circuit or the airway, it is called as positive pressure ventilation, PPV. So controlled ventilation is called as PPV and spontaneous breath is called NPV. All right. So PEEP is a very, very important function in a ventilator or an NIV, which prevents the alveolar collapse, basal atelectasis of the alveoli, improves oxygenation without increasing the FiO2. Without increasing the FiO2. All right. O2 flush is a part of intermediate pressure system of the machine. It is not PPV. PPV is a method of ventilating the patient. So how do you ventilate? Artificially. Ambu bag of the circuit, or bag of the machine, or the bellows of the ventilator, they give PPV. Okay. I don't understand. What is the relationship between RSI and vital capacity, breath, and tidal volume? You first tell me. Why? How is RSI and 8 vital capacity, breath, or tidal volume related? Change is good. Tell me. How are these two things related? Sure. Smish, I will definitely pass on your message to Dr. Sumer sir, and hopefully he'll keep this session. Whenever you need emergency oxygen supply, you use O2 flush. So why RSI? Why RSI? You talk about pre-oxygenation, no? You talk about pre-oxygenation. It doesn't matter whether you do it in RSI or not. It has nothing to do with RSI. Pre-oxygenation in itself means increasing the safe apnea time. There are two techniques: 3-minute tidal volume and 8 to 10 vital capacity breath, which is most commonly used 3-minute tidal volume. Okay. You should remember everything in BLS and ACLS. I teach ACLS, I don't teach ATLS. And it's not just update that you have to remember. Every single word of BLS and ACLS you have to remember. No, you have written in notes in RSI because it is one of the components of RSI. But I have discussed pre-oxygenation in detail in the pre-operative assessment and preparation. So what I am telling you is, it is not just RSI which is associated with pre-oxygenation. You do pre-oxygenation in every case of general anesthesia, not just RSI. One of the steps of RSI is pre-oxygenation. But I also taught it in pre-operative assessment and preparation, the last topic before we started monitoring. Are Baba, what new update? I'm telling you, you have to remember the entire guidelines. Why are you focused only on new update? Forget about the new update. There are 10 pages of guidelines. Remember that. That is what is going to be asked in the exam. All right. So that's it from my side. All the very best. Keep your calm. Keep working hard. Keep revising. Don't get bored. Last few days. After this, you would have to never go through this journey again. Just remember last few days. All right. You can use other drugs in modified RSI. Apart from thio and scoline, you can use rocuronium for muscle relaxation, and you can give gentle positive pressure ventilation with keeping airway pressures less than 20 centimeters water. That is the difference between modified RSI and RSI. Most common cause of post-discharge readmission after a daycare surgery is pain. Second most common cause is the respiratory depression due to over medication by opioid medications for pain. Understood?